Thank you for this invitation and for this introduction. So let me present my screen. Okay. Just a minute. So can you see my screen? Can you see my screen?
Now, yes, we can see your screen. Thank you.
You can. Okay, perfect. So Philip actually already addressed a number of things that there are the basis of this concept of the goal-directed perfusion. So I will try to do a little bit of history, of course, but actually look at the progresses in this field. And so let me start with a philosophical concept that everything is connected, and especially in the hemodynamics and even in the perfusion, everything is connected. We are speaking about the DO2. So you know better than me that DO2 is a combination of the oxygen content, so the hemoglobin, the oxygen saturation, and the PaO2, and of course the flow, the cardiac index. In turn, the DO2 is actually affecting other measures. I mean, depending on the DO2, we can have different oxygen extraction rate, different oxygen consumption, lactate production, and all this stuff. So the point is, what is this critical DO2? I mean, we are now quite familiar with this number of 280, but actually, where is this coming from? I mean, at the beginning, it was the anesthesiological and intensivist community that was actually experiencing on this. I mean, this is a very old picture, but actually what it's telling us is that you can decrease the DO2 and nothing happens to the VO2 until a certain level, and then you have the DO2 dependency, and you will lactate rising up at this time. This is a critical DO2, and Philip already showed you this. I mean, if you have a decrease in the DO2, then there is no problem with the VO2 until a certain point. You will extract more oxygen, the SVO2 will go down, but lactate will stay low until you reach again a certain critical DO2. And so we have two markers of this, the peak blood lactate and the nadir SVO2. One is expression of the anaerobic metabolism, the other one of the oxygen extraction. So again, look at this figure. Here we have a decrease in DO2. DO2 is not enough, but it is compensated by a higher oxygen extraction. No lactate. You still are in a compensated condition. But if you go here, then you have hyperlactatemia. You have an extreme venous desaturation. I mean, it could be 50%, 40%. This is a shock. Actually, it's perfectly the definition of a shock, that is not enough oxygen to the organs. So how much is this critical oxygen delivery, not on CPB, I mean in the intensive care, in critical care patients. So this is a very old study, again, something like 40 years ago, about 313 anesthetized men. And here is another one, more recent, but actually, again, in conscious men, you can go down to 7.3 milliliters per kilo per minute without having hyperlactatemia. See here, you go down with DO2, no hyperlactatemia until you reach a certain level. So if you look at this data, then could be 330, could be something like 280. However, should be somewhere around 300 milliliters per minute per square meters. And again, below this value, there is hypoperfusion, there is dysoxia of one or more organs, and this is the perfect definition of a shock. So based on this, the intensivist, anesthetist, they introduced this concept. It was a goal-directed therapy. We want the patient to stay in a certain level of DO2, not that much extraction of SVO2. We want the patient with an SVO2 of about 70%. So what can we do? We increase the oxygen content by optimizing the ventilation. We increase the oxygen content sometimes by transfusing the patient, and then we increase the cardiac output. And so this is the goal-directed therapy to maintain an adequate DO2. But on CPB, well, on CPB things are the same and probably even more, let's say, comfortable, because we don't have to use inotropic drugs to increase the pump flow. We just have to turn a knob whenever we can. So going to the history, we started with the concept that the hematocrit on CPB is a determinant of acute kidney injury, and this was 30 years ago. And then other researchers confirmed this. This is a very important study. Every kind of complication seems to be associated, at least, with a decrease in the hematocrit on CPB. And so the oxygen content matters, for sure. The point is, and so and flow, is the flow important? So again, about 20 years ago, and Philip already showed you this study very briefly, we tested the oxygen delivery. And yes, it was important, more important than the hematocrit. Because if you have a low hematocrit, but you can maintain a nice oxygen delivery, then your acute kidney injury rate will not be that high. And then again with Philip, we could actually confirm this in a multi-center study, and we sorted out with more or less the same value, 260, 280, someone is telling us 300, this is the range. And we could confirm that if you follow a goal-directed perfusion strategy, then you will actually reduce by about 50% your acute kidney injury rate. So flow matters, of course. It's a combination of the two. And so this is, let's say, some months ago when we published these guidelines. So that's why we placed GDP in class 1A and even the threshold in class 2A, that is, again, between 280 and 300 milliliters. So this is confirmed. It's somewhere around 300 milliliters. But as Philip very nicely introduced, okay, this is a mean value. But it could be that in some patients we need more. It could be that in some patients we even need less. And so this is the point. Yes, we start with the oxygen delivery, but there are certainly other factors, apart from the DO2, that may affect organ function during CPB. And I'm very happy that Philip quoted Charles Fildevor, because I've been a pupil of Charles. So, and I always remember this statement: we need an online CPB monitoring to tell us, like a cruise control, whether or not we are doing a good job. So we introduced this concept a couple of years ago. That is, we were looking to another set of variables that could be determinants of acute kidney injury, and we ended up with a number. Okay, the nadir hematocrit was already known, the nadir DO2 was already known, but we found other linear correlation, or even let's say polynomial correlation: the time of exposure to a low DO2, the nadir mean arterial pressure, and of course CPB duration. Lactates, where they are not determinants, they are just a marker. But even transfusion on CPB were increasing the risk. So we created this multifactorial dynamic perfusion index that is inclusive not just of the DO2 but other parameters, and we ended up discovering that the prediction, the discrimination power of the MDPI was superior to the static models. We could reach 0.77% of an area under the curve, and in a second study 1 year ago, we did validate this same strategy, but this one was prospective, the other one was retrospective, and we sorted out with, again, 0.81 as a discrimination power of the multifactorial dynamic perfusion index. How do I see this in the clinical practice? Well, let's say this is a patient with 2 hours of CPB, and this is a nice behavior. I mean, 24%, 300 DO2, good blood pressure, no lactase, no transfusion. Then, if this is a simulation of these equations that are behind the multifactorial dynamic perfusion index, and then if you have a decrease in the hematocrit and you do not react, then you will have a decrease in the DO2, and then the risk will climb up to 10%. And then if the hematocrit declines again, a very low DO2, now you will see that there is lactate formation. Once you reach a level of about 2, then you have 20%. And you can even climb up to 30% if you have hyperlactatemia, transfusion, very low oxygen delivery. So this is what I, let's say, would like, and I'm quite sure that I will probably, see on the monitor of the perfusionist so that he can act, because there are things that can be modified. You can hemoconcentrate the patient, you can increase the pump flow, and these are some of the possible interventions. So let me close with something that we are presently working on. These are unpublished data, and I think you will very soon find them in the literature. And this is to answer and to address the point that Philip raised. Not all the patients are the same. This number, see here, 280, it's not a magic number, it's the mean level. So, of course, if you stay below, then your acute kidney injury rate will be 27, and if you stay above, will be 13. So, risk ratio 2.4. And this is actually fun enough. Every kind of study will sort out with a risk ratio or odds ratio of, let's say, 2 to 2.5. So it's true. This is an important threshold. But look at this. This is okay. You stay above and you will not have acute kidney injury because this is the line of an increase of creatinine of 1.5. So this is the international definition of cardiac surgery associated acute kidney injury. So we are okay this. True negative. You will not develop acute kidney injury if you stay above. This means in statistical terms, you have a negative predictive value of 86%. That is quite high. I mean, if I stay here, I'm quite sure that in 86% of the cases, we will not have an acute kidney injury. So we are happy with this, but let's look at this. There are false negatives. This is what we call now a DO2 independent acute kidney injury. Despite the fact that you stay on the right side, then you still have acute kidney injury. And on the other side, okay, you stay below, and so you have a DO2 dependent acute kidney injury. These are the patients. But actually the positive predictive value is quite low. Well, we are not that much interested in the positive. We are more interested in the level that is negating the possibility of having an acute kidney injury. So the negative is much more important. But this again raises a question. So we have a number of false positive patients that stay below this threshold, but they do not develop an acute kidney injury, and they are many. So the question that arises here is which factors determining having a low dependence to the low native VO2. So staying here, and which factors determine having acute kidney injury at a normal or even high oxygen delivery. So we went to, these are more than 1,000 cases. And so we could investigate this. And I can tell you, in this area, we have the elderly patients, we have anemic patients, we have prolonged CPB time, and of course we see a high peak lactate, relatively high. While in this area, we have young people, we have a higher hematocrit, we have a relatively short CPB time, 1 hour and a half with respect to 2 hours, and a lower level of lactase. So we can discriminate. And actually, if you look at this is the effect of the CPB duration. Of course, the longer, the higher is the risk. But look at this. If you stay above the threshold, then your risk will be quite lower than in people where you stay below. But we cannot do anything about CPB duration unless changing the surgeon. I mean, so we cannot act on this. We can on this. I mean, of course, we cannot change the age, but this one, to me, I'm still looking at this picture and I'm not totally sure that I can understand this. But actually, you see that for the same age, if you stay above, then you say, let's say at 60 years, you will have 7% risk. But if you stay below, you will have 3 times higher risk. So what should we do? I'm not totally sure, but probably we should consider, let's say, a patient-specific level of DO2 based on a number of conditions that we are now studying. I think at the end of the day, we will still confirm, of course, that DO2 is important, but then we can adapt the threshold value to the condition of the patient. Someone is in need for a higher level, someone for a lower level. So thank you very much for your attention.
Thank you very much, Dr. Ranucci. It was great, and we are honored to have you present in our webinar. And now, Balanika Marina, she is the Director of Anesthesia at Onassis Cardiac Center in Athens, Greece, will make a comment. Thank you.
Good afternoon, everybody. I would like to thank Professor Ranucci for his excellent presentation, and I would like to thank the organizing committee for inviting me here. As Dr. Ranucci has, Professor Ranucci has mentioned, the goal-directed perfusion is a well-defined, is evidence-based strategy already to protect, aiming to maintain this, to maintain perfusion DO2 above a certain above this critical value, in order to decrease the incidence of acute kidney injury during cardiopulmonary bypass. I would like to mention that, to point out that Onassis Cardiac Surgery Center, Onassis Hospital, is the unique institution in Greece having the privilege to use this monitor in real time in everyday routine, and that we usually combine it with a goal-directed anesthesia goal-directed therapy approach. And we have observed that this gives us the opportunity to a better decision-making intraoperatively and to optimize patient outcomes, and especially for our high-risk cardiac surgery patients. Thank you very much.
Thank you. If I can just add a little comment. Of course, we are now looking very strictly to this concept of DO2 delivery independent acute kidney injury. So you have seen there are some predisposing factors. But at the end of the day, I think the great majority of these patients actually are those who, after CPB, are experiencing a low cardiac output. And so, because of, let's say, they could have many problems. It could happen in the intensive care unit or immediately after weaning from CPB. And so this is why the transition from the goal-directed perfusion to the goal-directed therapy is very much important. I see a question on the screen, so I can probably answer the question, that is, does the age of the patient impact? Absolutely, yes. If you look at my one of my last slides, we could now see, and it was the first time that we addressed this, that of course age is always a determinant of acute kidney injury, but for those who are treated with goal-directed perfusion, then the risk at the same age is about 2 to 3 times lower than for those who stay at the low level of oxygen delivery. But presently, I cannot totally answer the question. So if you ask me what is the threshold that we should maintain, the level that we should maintain for an 80 years old man or a 40 years old man, I cannot tell you anything, but I think sooner or later we will be able to give an answer to this.
Thank you, Dr. Ranucci. It was a great presentation. And now?
Now, I'm very glad to introduce the Ignacio Condello,